provide appropriate prenatal care for mothers and their babies through monitoring and time intervention, and such screening too will be useful in constructing clinical decision rules and may also inform future studies to explore prophylactic options or therapies. Like I say, prevention is better than cure, hence the need for this study. Several guidelines have been advocated to find ways to determine early onset of this disease, like the WHO had advocated for routine blood pressure check whenever women present for antenatal booking and for subsequent clinic visits. And also, the mean arterial pressure had been noted in addition to other maternal factors to improve detection rates of early onset and late onset of this disease. This was a study done by Payne and Poole in the last century. There's also evidence to show that higher pre-pregnancy body weights are also associated with development of preeclampsia, anemia, like we know, and also high hematocrit level have been associated with adverse maternal outcomes and perinatal outcomes like intrauterine growth restriction, preterm birth, and low birth weights. Proteinuria in its severe form has also been known to worsen outcome. The method that was used, there was a prospective study of pregnant women attending routine antenatal clinic at selected primary healthcare center who mostly referred patients to the teaching hospital for further care. Eligible women who were less than 14 weeks gestation with no prior history of chronic hypertension or other forms of hypertensive disorders or pregnancy-induced hypertension were selected, and the ultrasound scan that was done was to just rule out gross fetal anomalies, and the primary outcome of interest was the development of preeclampsia. The sample size was calculated and obtained 10 events for which 14 candidates variables were included in the prediction model, anticipating an 80% at 5% significance level by a study done by ANICBA in 2019. A total of 450 women from the 12 participating health facilities were recruited, and in the model construction of these 450 women, a further validation cohort of 150 women were drawn from the original population, and the rates of hypertensive disorder of pregnancy in the derivation cohort and the validation cohort were both 30.7 and 25.3% respectively, for which this was further subject to a multivariate analysis and binary logistic regression analysis. The tables displayed below. This is the first table for which these 12 variables were noted, which had to do with weight at booking and weight at 28 weeks and 36 weeks, and other parameters were the mean arterial pressure at booking, 14, 20, and 28 weeks, and also their PCV levels. This was further broken down, having analyzed that we had a logistic regression model to predict high for hypertensive disorders of pregnancy, for which 5 of these variables were significant. This had to do with their parity, the mean arterial pressure at 20 weeks, at 14 weeks, and also at 20 weeks for their PCV as well. The results had reviewed a univariate analysis, which was established at 12 and 14 of these variables, as mentioned earlier. And following these, 5 of these variables of the 12 that were selected noted the parity, mean arterial pressure at 20 weeks and hematocrit at 14, 20, and 28 weeks respectively were significant, with a high risk dependence rate of less than 0.5 as p-value. This was further subjected to a binary logistic regression was conducted with these 5 independent variables. The new model was statistically significant at 84.4% with a p-value of less than 0.01. Also, taking a reference score of 5, 0.25 was noted to be of low risk, while 5 and above were noted to be of high risk. And women with low risk were 12 times lower than women categorized as high risk, of 4.4 and 52.4% respectively. The high risk category approximately was about 3/4 of this study population. The area under the curve obtained from the internal validation had noted 95% confidence interval, and the low risk category women offered 44 times lower risk of hypertensive disorder of pregnancy than those of high risk, about 1.5 versus 56.9% respectively. The sensitivity of the study was noted to be 73.7 with a specificity of 92.9. Yes, sir. Conclusion, sir. Yes, sir. Thank you, sir. In conclusion, we have noted that this study has shown that the hematocrit at 20 weeks predicted hypertensive disorder of pregnancy, and this finding supports our previous reports that this was strongly correlated. And in our study, we also noted that parity was also significant, as well as the mean arterial pressure and hematocrit levels at 14, 20, and 28 weeks. A larger study involving more healthcare facilities will help to confirm our findings and serve as external validation for our simple multi-parameter prediction model in other populations. These are my references. Thank you very much.
Thank you so much. Thank you. Clap for him. Is there another presenter?
Yes, sir. OR 67.
Number what?
67, sir.
If you do us for you, we thought there were 6 of you, so the number keeps enlarging. Huh?
Can I start?
No, you can't start. Number what again, please?
67.
6, 7. The presenter is who?
Dr. Adetunji Laura.
Adetunji L. Okay. Yeah, you can start.
Okay. Standing on existing protocol, I'm Dr.
You have 6 minutes. 6 minutes, please.
Okay, thank you, sir. I'm Dr. Adetunji Laura Nengi, a senior registrar in University of Benin Teaching Hospital, and I'll be presenting diagnostic challenges and multidisciplinary management of a case of postpartum spontaneous pneumothorax, and these are my co-authors. So I'll be utilizing this outline. Spontaneous pneumothorax is extremely rare in obstetric practice, hence the report of this case. The prevalence is estimated to be 1 per 10,000 deliveries. Usually with spontaneous pneumothorax, there is a sudden collapse of the lung with accumulation of air within the pleural cavity. It's life-threatening and it requires a high index of suspicion. The condition is rare, and authors therefore report their experience of spontaneous pneumothorax in the postpartum period with a view to improving care in subsequent patients. A 35-year-old para-3 lady who had cesarean section using regional anesthesia 3 weeks prior to presentation in another facility for twin gestation with leading twin breech, presented with complaints of dyspnea of 1 week duration, which had progressively worsened. There was also history of orthopnea and chest pain, but there was no cough, no fever, and there was no pedal swelling, and she had no history of trauma. On physical examination, she was dyspneic and tachypneic with respiratory rate of 50 cycles per minute, and oxygen saturation was 93% on oxygen. There was tachycardia with pulse rate of 110 beats per minute. The abdominal and vaginal examinations were unremarkable. So multidisciplinary care was instituted for this patient by the obstetric, cardiothoracic, intensive care cardiology, and physiotherapy units. CT pulmonary angiography did not show any features of pulmonary embolism, and echocardiography showed left ventricular hypertrophy. What actually gave away the diagnosis was the chest x-ray that was done, which showed features of left pneumothorax. It was a diagnostic dilemma because the initial working diagnosis was a peripartum cardiomyopathy based on the history of dyspnea with associated orthopnea. However, the diagnosis was given away when she did an x-ray that showed a left-sided pneumothorax. In the intensive care unit, she had a non-rebreathing face mask to improve and maintain saturation. She had emergency closed tube thoracostomy drainage, following which symptoms improved remarkably. Chest physiotherapy was also performed to improve recovery. She was subsequently discharged home and has been followed up for 3 months without further complaints. So this is the chest x-ray. There is an area of hyperlucency above a radio opaque white line, which shows the pleural margin of the collapsed lungs. And this is the second chest x-ray after resolution of symptoms, where those features are resolved. So in pneumothorax, air enters the pleural cavity on inspiration because of a ball valve mechanism, but does not exit on expiration. There is therefore progressive enlargement of the pleural space and increased intrathoracic pressure. Venous return to the heart is decreased, which leads to decrease in cardiac output. The risk factors include respiratory tract infections such as pneumonia or tuberculosis. However, this was not present in this patient as she had no prior history of cough or fever.
2 minutes.
She wasn't a known asthmatic patient. And other risk factors include previous history, hyperemesis gravidarum, trophoblastic tumor, family history, cocaine use. All these were not elicited in this patient. Iatrogenic pneumothorax may also occur following insertion of central venous lines or endotracheal anesthesia. However, this patient had a regional anesthesia, so this was not implicated in this patient. The diagnosis could be challenging as it is mainly based on symptoms and chest radiograph findings. And we also want to emphasize the importance of chest radiograph in patients who are either pregnant or in the postpartum period with significant chest complaints. And this was what gave up the diagnosis for this patient. This should not be withheld over concerns of exposure of the fetus to radiation because the benefit may far outweigh the risk. Cardiac disease and normal physiological changes in pregnancy have similar features to pneumothorax, which may prevent early diagnosis, as was the case in this patient. Other differentials are venous thromboembolism, pulmonary edema, amniotic fluid embolism, acute exacerbation of asthma, and pneumonia. The options of treatment include needle decompression, pleurodesis, thoracostomy, which the patient had, and thoracoscopy. Prolonged intercostal drainage, as seen in the index case, where there was symptomatic large pneumothorax, is safe and effective. Supplemental oxygen accelerates the rate of pleural absorption, but observation may be justified in small asymptomatic cases. So in conclusion, spontaneous pneumothorax in pregnancy or postpartum period is extremely rare. It should be considered in the postpartum period in patients with dyspnea. Diagnosis could be challenging as symptoms may mimic normal pregnancy or cardiac disease. Symptom analysis and chest x-ray will aid in diagnosis. Chest tube thoracotomy is an effective method of treatment, and early recognition and prompt multidisciplinary management are key to maternal survival, as was in the index case. These are my references. Thank you for listening.
Thank you so much. Do we have any other presenter? Okay, I guess, Yeah, I guess we are done. So we are now ready to take questions per presenter. You may accept 1 or 2 per presenter. If you have any, please mention the presentation of your interest and ask your question. Presenters, please take note so that I come and answer after we've collected the questions.
My question goes to the presenter on the risk prediction model for, is that preeclampsia, right? So you presented a beautiful work, the risk scores and the parameters, but when you did the receiver operator characteristic curve analysis, you didn't tell the optimal score using that prediction model that can predict preeclampsia in a patient with a certain level of accuracy or certainty. So I was expecting to see that, okay, a score of 8 has so and so specificity, sensitivity, positive predictive value, negative predictive value for predicted preeclampsia, but I didn't see that. It just gave us ranges and all. I don't know if you can address that. Thank you.
Thank you. Take a second question.
Thank you, Chairman. My question goes to the doctor who that presented the case on had to do with spontaneous pneumothorax. Thanks for your presentation. I don't know, I did not really quite hear well. I would love to know your clinical findings when you examined the chest. When you did a respiratory examination, what were your clinical findings? Thank you.
Please be noting the questions that are affected.
Okay, thank you very much. The very last presenter. First of all, I'm proud of you being a Bini product. You've done very well. I love your lucidness and keeping to time. It's just two simple things. How long was she on admission before, the last presenter, before you discharged her? It would be nice to know. And I noticed that there was no anesthetist, even though you said, in your list of contributors to the work. So I know that you can't go and manage an intensive care unit without an anesthetist being present, and you didn't mention that. Otherwise, well done.
Thank you.
Thank you very much. I want to congratulate all the presenters first for the job well done. I have a few questions. One to the presenter on management challenges of pregnancy-associated breast cancer in a resource support center. I'm not sure I heard you about the gestational age at presentation with the patient and the gestational age at delivery. I think then the patient defaulted years, but eventually had surgery done at 36 weeks. At that 36 weeks, you still did not deliver the baby. What are you waiting for? Why did you have to wait for mastectomy? Completed the size, the effect of the trauma of that major surgery, on the cardiovascular status of the patient and possible effect on the fetus. And because also the patient needed chemotherapy. You said chemotherapy should be avoided in first trimester, but eventually you did not give it until postpartum. So I'm a bit, I don't know, I want you to throw more light on that. Then also, for the person that presented on comparative studies of pregnancy complicated by HBSS, and you mentioned that preterm delivery was one of the complications that were noted. I want to find out, these preterm deliveries, were they basically complications of the pregnancies or they were iatrogenic? Because we do know sometimes you may have to, deliver preterm because of the other complications in pregnancy to safeguard the life of the mother. Finally, the third question goes to the presenter on the understanding and addressing critical gap in pre-eclampsia management. Insight from
presentation 50 that talk about understanding and addressing critical gaps in preeclampsia in Kano State Primary.
Thank you so much. You will tell us why they are managing
Thank you very much.
preeclampsia and the PSC. Thank you. Go ahead.
Yes, I have some questions on the popsicle trial. Very interesting findings. However, could you please shed some light on the comparison between the pulmonary complications in the hemoglobin SS and hemoglobin SC group? Because we used to know that one of the important difference in terms of morbidity in these two groups is the increased risk of pulmonary complications. What did you find in your study? Also, an interesting finding on the positive correlation between the hemoglobin S concentration and the perinatal outcome. We also know that some advocate for EBT, particularly in patients that have more complications during the course of pregnancy, which should have a good correlation with the level of the hemoglobin S as well. So would you recommend EBT in such patients in order to address the increased perinatal morbidity and mortality that you found as well? I also have a comment on the spontaneous pneumothorax case, very interesting case. You mentioned that you tried to rule out history of trauma in the patient, but being that the patient was referred from another center, did you try to possibly rule out possibility of Creed's maneuver? You did mention that the leading twin was breech. Were there any obstetric maneuvers that were attempted that may have predisposed the patient to spontaneous pneumothorax? It was interesting that you mentioned that the patient had CTPA before the chest X-ray finding, and I found it quite interesting being that whatever the diagnosis or differentials may be, even if it were pulmonary embolism, for instance, in which case you would use CTPA to confirm the diagnosis, it is routine, even in high resource settings, that you do a chest X-ray first before you do a CTPA. So was that the case in your patient? Thank you.
Yeah, please, let's restrict the questions. I thought you were tired. I can see energy too much.
Good evening, everyone. Some of my questions have already been expressed, but I still want to ask additionally, the lady who had the breast cancer in pregnancy, what was the gap between the mastectomy and the cesarean section? What was the benefit? I think they've already asked. What's the benefit of doing a mastectomy in third trimester instead of waiting? Why wasn't the baby delivered so that she could face the cancer treatment? What were your anesthetic challenges in doing a radical mastectomy in third trimester? I would like to hear what happened in theater and how was it managed. Your antibiotic regimen following the two surgeries, were they the same or were they different? And based on what did you choose those antibiotics? Thank you.
Yeah, I guess, okay.
The chairman of this session and senior colleagues and colleagues, I stand on existing protocol to congratulate the presenters, and I just want to give some comments and some questions. So generally, I have a bias for methodology and statistics, and because of that, I will generally say that we should pay more attention to most of our works, because when we want this work, majority of what is presented here may eventually want to go into journal articles. If we want to target high-end journal articles, you may need to do more work on your statistics and your methodology. So back to some specifics, just a few. For the presenter on mixed method on HPV, you mentioned that your study was a descriptive study, but along the line, you told us that you ran logistic regression. Please, there's a contradiction there. If you eventually conducted a logistic regression, which means you showed us p-values, that means your study is no more descriptive. It's in the realm of analytical cross-sectional or comparative cross-sectional studies. All these terminologies are not difficult. If a fellow gynecologist, can pick them, all of us can. So please don't let us keep thinking we should push all this to statisticians. No, because here, your statistician is not here with you. And if we start asking you questions at international fora about your statistics, you must answer us. So, and that is why all of us must immerse ourselves in these things so that we know them very well. So, to the breast cancer work, I also want to follow the last presenter to say, I am not sure if breast cancer is an indication for a cesarean section. So what was the indication for that cesarean section? Then you mentioned it like 4 or 5 times. Is it really sacrosanct that termination, you said termination is not recommended. Termination is not recommended. So I think we need to really modify that statement for those people in the oncology space. That is it that virtually all, when you have a patient that is pregnant and has breast cancer, then there is no place for termination. Is that what we want to project? Of course, as I said, I don't have so much competence in that area, but I want to be sure that that is the exact thing that we should discuss. Then, for these patients too, we need to also talk about the contraception, postpartum contraception. Was there any idea about you were able to counsel this patient about postpartum contraception?
Thank you.
And moving forward with that too, we need to also be careful about their there are issues around sexual dysfunction that is related to the chemotherapy they are taking. So these are issues that we need to always check up whenever we are having a patient with cancer, any of the gynecological cancers, and that we won't be able to manage successfully.
Thank you so much.
Sorry, sir. Let me just take this last one, sir.
You are taking up to 6 minutes for presentation.
I'm sorry. Okay. Should I, sir?
Go ahead.
All right. So the last one is on the, though I have some other one, but I will discuss internal one-on-one with them. The last one is on the patient, my colleague that presented on maternal outcome, maternal mortality. There is no way you will come up with a maternal mortality study that you shouldn't come up to calculate the maternal mortality ratio. So all through, you didn't mention anything about the maternal mortality ratio in your study. So as I'm handing over the microphone, I will also say that there are some of the studies that have what we call time to event analysis, like the preeclampsia study and some other study. Think about it, that you may need to also consider bringing in time to event. Like that study, you may also consider time from recruiting the patient at 14 weeks and when they eventually develop preeclampsia. That may make you want to run some cost proportional hazard resection. So I thank you also.
Yeah, we may not be able to take another question. The last colleague has asked all our questions. If I don't ask question, I get as it go be now. Now the number 2, management challenges of pregnancy associated breast cancer. Did you do genetic counseling for that woman? Let me stop here because of time. So, presenters, please, you have 2 minutes to answer the questions thrown to you. 2 minutes, let's start from the person nearest to the microphone.
Thank you all for your questions, comments, and criticisms. They are noted and well taken. I'll be starting with she presented at, answering the questions for management challenges of pregnancy associated breast cancer. The patient presented at 28 weeks of gestation, and we counseled her for mastectomy and chemotherapy to commence after the mastectomy, but she presented late. She presented at 30. She came back after 8 weeks, that's at 36 weeks of gestation, and she had the surgery done. We would have commenced chemotherapy, but chemotherapy is meant to stop 3 weeks before term because of the high risk of infection and hemorrhage that could occur with all the white blood cell suppression and platelets, thrombocytopenia that could occur with chemotherapy. So we usually stop it 3 weeks before term, but she came at 36 weeks. So we planned her for chemotherapy after delivery of the baby.
Sorry, is it possible that a woman could have had chemotherapy?
Yes, you can have it in
only then you deliver the baby, then before you do the surgery. Is it possible?
Yes, you can have a new.
But I think that's where they are going now. Than putting the woman through surgeries in pregnancy.
So, breast cancer in pregnancy is not an indication for cesarean section, but the obstetric indication is more important for the patient. For this patient, we actually counseled her on concurrent surgery, elective cesarean section and mastectomy, but she declined. She wanted to have a spontaneous vaginal delivery. And we eventually did an obstetric scan that showed a breech-presenting fetus that now made us counsel her, and she agreed for an elective cesarean section eventually. That was also part of our management challenge.
It's okay, thank you. Second person nearest. You know your questions now. Not more than 2 minutes, please.
Thank you for your questions, comments, and criticisms. They are well noted and taken. Concerning the score prediction, we had categorized it from 0 to 12, for which we said 0 to 5 is low risk, and greater than 5, which is 6 to 12, it's high risk. And for a score of 8, is also actually categorized as part of high risk. And for the two cohorts that were used, the derivation cohort and the validation cohorts, both their positive predictive values were 52.4 and 56.9% respectively for the validation cohort, giving it a negative predictive value of 95.9%, and this was quite significant. And for the validation cohorts, had a sensitivity of 73.7% with a specificity of 92.9%.
So you did it now. I just wanted to know whether you did that. It's okay. Don't come and present it again.
The table that was shown.
Thank you so much.
Thank you, sir.
The next person. In abstract presentation, I think we should know what to highlight. You don't spend the whole time presenting on background and literature review. No, we're interested in your results.
Thank you very much for the questions. I will take, there are 3 questions on the PIP-SICKLE trial, and I will just answer everything, Mr. Chairman, sir. So the first question is on the chest complications for hemoglobin SS versus hemoglobin SC. The interesting thing was that the findings from the study was hemoglobin SC patients had more frequent crises than hemoglobin SS, but in terms of severity, all other complications were higher in patients that had hemoglobin SS compared with hemoglobin SC. So why those ones had to tend to have more frequent complications, SS had very severe complications, all the complications. The question on preterm birth, thank you very much. That was a very critical question. 70% of the preterm birth in that study were provider-initiated deliveries due to complications in the pregnancy. Roughly about 30% had spontaneous labor, but the majority of those preterm deliveries were provider-initiated deliveries. The last question, which is a very excellent question, was on exchange blood transfusion. The underlying mechanism behind exchange blood transfusion is to increase the concentration of hemoglobin AA, thereby lowering the concentration of hemoglobin S in those patients. And we have explained that the complications worsen with that. So while it sounded alluring to do exchange blood transfusion for them, there is sufficient literature to show that the more transfusions you do for these patients, the higher their chances of developing antibodies, red cell antibodies that make further transfusion difficult. And you know you need larger volumes of blood to do exchange blood transfusions. So unless the patient develops acute chest syndrome, infarctions, or thrombotic stroke, you don't want to use exchange blood transfusion as your primary routine of management for sickle cell patients. Thank you very much once again, sir, for the opportunity.
Thank you, Dr. Ibrahim. Any other standing question? Okay.
Thank you for the questions. So, Professor Imari Jaye is actually an anesthesiologist. Sorry, that wasn't highlighted. Okay, so that was an error on my part. Sorry about that. Then the patient spent about a week on admission. Then on the chest findings, the chest was clear on auscultation. However, what could have hinted or given away the diagnosis prior to the chest X-ray was a percussion, but this wasn't done. On percussion, it would have been hyperresonance, but this wasn't done for the patient. Sorry about that. Then lastly, there was no report of any maneuver from the patient. And then the order in which the investigations were reported was not necessarily the order in which they were done. Thank you.
It's okay, thank you. The primary health care and pre-eclampsia, I think that's what we want to hear now. Is it you?
Yes.
Please.
Okay, thank you.
We are worried. You understand our question?
Yes, yes, I understand it quite clearly, sir. So I think the 2 questions were similar. It was about the rationale for the study. So the first thing, the rationale for the study was about understanding the landscape of pre-eclampsia in Kano State. Yes, we acknowledge that at the primary healthcare level, the instruction is if you make a diagnosis, you refer. However, in states like Kano State, they have home deliveries of over 70%. And very often, when they have those conclusions, they come to the facilities. And so, when we found that the healthcare workers, just 36% of them were nurses, those were cadres below nurses. If a woman has an eclamptic fit, she's going to come to the primary healthcare facility. And there's magnesium sulfate there, but they did not know what to do with it. And then they refer her with the convulsion to start traveling a distance to try to receive care. So what we're trying to find is that those healthcare workers, no matter the cadre, at least if they have a simplified regimen of magnesium sulfate, when the women come with the convulsion, they can at least administer magnesium sulfate before referral, because most of them do not even attend antenatal care. And they are the facilities that are closest to these women. So that was the rationale for the study.
Yeah, you should have been specific in your statement. You said management. Should I at least say initial management? Because we don't expect a primary health care center to be managing such severe cases. But now you've clarified it, so thank you so much. The person that presented on comparative analysis of pregnancy complication between HPSS and HPSC, I asked, how did you control for confounders? You said it's a cohort study. How did you control for confounders?
Well, thank you very much, sir, for that question. I think the major thing we did was to exclude patients with significant medical history. That was the major thing we did before the analysis. Because in the main PIPSICO trial, we recruited 476 participants. But for this sub-study, which I presented, we excluded only those that had HIV, diabetes, hypertension, and all that, and then we proceeded with the rest of the analysis.
The exclusion, did it take care of the possible exposures that, might confound the outcome?
Well, because we are looking at complications, we felt that this significant medical history could bias the results. That was what we just focused on.
It's okay. Thank you so much. I guess we've attempted all questions. We are so grateful on behalf of Dr. Yangete and myself. We are so grateful to all the presenters for the wonderful presentation. You can see the responses you stimulated. I'm sure if this was done in the morning, more questions will have been coming out. We have to go and thank your God that we are doing it by this time. We thank Sogon for giving us this opportunity. The chairman of the scientific committee, thank you so much, and all our colleagues for staying behind. Thank you so much. Do you have anything to say, sir? Just say something.
Yes, just to say thank you. I think it has been a very interesting session, very useful contributions and questions have been asked. So thank you very much. I think we are done for this session.